Very good evening to all of you. I welcome you all for this last academic activity of neuromuscular and neurogenetic SIG. And today I have an interesting talk by Dr. Ingrid team on the update on management of fatty acid oxidation defect. I request our President, Dr. Shefali, to introduce the expert and the moderators for today's session. Go to you, ma'am.
Thanks, Mahesh. Last month we had the neuromuscular SIG. We are having 1 month for each SIG, and this time we had concluding this 4th week of neurometabolic and neurogenetics. We had to combine both the SIGs together, and we have none other than Professor Ingrid Tain, who needs no introduction. Everybody knows her globally, who is the founder and director of the Neurometabolic Clinic, Investigational Unit and Research Laboratory since 1991, staff neurologist in the Division of Neurology, Senior Associate Scientist Emeritus in the Genetics and Genomic Biology Program in the Research Institute at the Toronto Hospital for Sick Children, and Professor Emeritus in the Department of Pediatrics and Lab Medicine and Pathobiology at the University of Toronto. She has been working exhaustively in all the neurometabolic disorders, and especially the fatty acid oxidation disorders, mitochondrial, paroxysmal, and cofactor responsive epilepsies. She was president of the International Child Neurology Association till 2018, and she has been on the board for last 2 decades or so. And she's received innumerable international awards, which are there to her credit. We are very lucky to have her here, and over to you, Professor Ingrid. And just before that, the experts today have been Dr. Biju Hamid, who we all very know very well, and dear friend. So that, and then Dr. Arijit Chattopadhyay, who is a very senior pediatric neurologist from Calcutta. Dr. Biju Hamid is traveling, so he will join in between. And I've requested Dr. Lokesh Limbaka, who is from Hyderabad, a very senior pediatric neurologist, to also join us as an expert. And moderators are Dr. Sangeeta Yoganathan and Vaishak. Over to you, Professor Ingrid. Can you start sharing the screen?
Can you see my slide?
No.
Not yet, ma'am. You can reshare your slides.
Okay. All right. Now I'm having trouble escaping. All right.
You can click on the new share, ma'am.
Okay. I seem to have got out of the Zoom room for some reason. Oh, wait a minute. Yes, now I have it. Okay. All right. Let's share. Okay. Can you see my slide now?
Yeah. Yes, ma'am. Yeah.
Okay.
Now it's full screen.
Okay. And it's full screen and very visible?
Yes, ma'am. Yes, ma'am. It's
Okay.
visible.
All right. And you can hear me clearly enough?
Yes, ma'am.
Okay. Well, thank you for this very kind invitation. These are my disclosures, which just relate to the grants that have supported our work over the years. So what I plan to do this evening in your time is to provide you with kind of a bird's eye view of the past 50 years in fatty acid oxidation disorders. And I hope to provide an understanding of the central role that fatty acid plays in human physiology, and highlight the basic pathophysiologic mechanisms in these disorders, because the mechanisms help to predict the cardinal clinical, biochemical, and pathological phenotypes. And I'll also highlight the toxicities, the specific toxicities of short, medium, and long chain fatty acids. I will then focus on our work. Oh, I'm getting an echo. On our work on the organic cation carnitine transporter family, and on SCAD and LCHAD deficiencies. And what I really hope to do is to provide you with a way of thinking about the pathophysiology of these disorders in terms of what's accumulating proximal to the block, what are those toxicities, what the deficit leads to in terms of cardinal manifestations. Because an understanding of the pathophysiology helps us to develop very targeted sort of precision medicine treatments. So just the early history, the pathway was first actually elucidated in 1950 by Theodor Leinen, a German biochemist in Munich. And in 1964, he and Konrad Bloch received the Nobel Prize for discovering the mechanism and regulation of the pathway. 20 years later, approximately, the very first clinical disorder of CPT2 deficiency was discovered by Dr. Di Mauro. And in 1976, Niels Gregersen identified MCAD deficiency, which is overall the most common of this group of about 20 disorders. Now, why are fatty acids important in human biology? Well, first, they serve three major functions. The partial oxidation of fatty acids by the liver produces ketones, and ketones are the all-important auxiliary fuel for almost all tissues, but particularly for brain during times of hypoglycemia. So this is a very critical biomarker. Also, fatty acids serve as the major reservoir of energy fuel in the body, and also it is the most efficient oxidative fuel. So therefore, it's very important in highly bioenergetically active tissues, such as cardiac and skeletal muscle. And thirdly, the high rates of hepatic gluconeogenesis and ureagenesis that maintain the balance in fasting homeostasis are sustained by the products of fatty acid oxidation, namely ATP, reducing equivalents such as NADH and acetyl-CoA. So this is the beautiful pathway of fatty acid oxidation. So during times of hypoglycemia, there's an increase in the glucagon to insulin ratio, and free fatty acids are liberated from peripheral adipocytes. So short chain 4-carbon and medium chain 8-carbon fatty acids flood to the plasma membrane and cross it, and the outer and the inner mitochondrial membranes, where they are then activated into their CoA esters inside the mitochondrial matrix. 16-carbon long-chain fatty acids, such as palmitate, are unable to permeate the high proteolipid composition of this inner mitochondrial membrane. So they must be taken across by a carnitine-dependent system and 3 enzymes. So CPT1, which is the rate-limiting enzyme for fatty acid oxidation, carnitine acylcarnitine translocase, and CPT2, on the inside of the inner mitochondrial membrane, which is the most common cause of recurrent myoglobinuria in adults and children, boys and girls. It is then activated into its CoA ester. So this is the proximal pathway of fatty acid oxidation. This is the distal pathway. Within the pathway, we have 4 steps: the acyl-CoA dehydrogenases, the enyl-CoA hydratases, the L3-hydroxyacyl-CoA dehydrogenases, and the thiolases. And the fatty acid is taken down, and at the end, a 2-carbon fragment of acetyl-CoA is cleaved. There are chain length specific enzymes for each of these steps. Acetyl-CoA that can be then completely oxidized in the Krebs cycle, or it can be converted by an HMG-CoA synthase and lyase into the all-important ketone bodies. So why are these disorders important? Well, first, they're potentially rapidly fatal and a source of major morbidity. And the early recognition and prompt institution of therapy and preventative measures may be truly life-saving and can significantly decrease the morbidity and mortality in this group of disorders, and can make the difference between a child who grows up with good cognitive function versus one who has marked intellectual disability and seizures. Also, they're all autosomal recessive in inheritance. So there's oftentimes a positive family history of, for example, sudden infant death syndrome, and it's very important to screen the siblings. So just to provide you with a kind of physiological view into the bioenergetic demands of the brain, you'll note here that the young child's brain consumes almost double the cerebral oxygen consumption of the young adult brain. And this constitutes greater than 50% of the total body resting oxygen consumption. Now, this high energy demand likely correlates with the rapid growth of the brain in the first 3 years of life to about 75% of adult size. But this high metabolic rate continues until about 8 or 9 years of age, which likely relates to the very active synaptogenesis and dendritic barbarization that is occurring. And it also underlines why the young infant's and child's brain is exquisitely vulnerable to hypoxia, hypoglycemia, and hypoketonemia. And it explains why these defects of cerebral energy metabolism become clinically symptomatic during this time period. Now, why are children particularly susceptible to fasting stress, which is the major precipitant in all fatty acid oxidation disorders? So again, if we think physiologically, infants have a much larger brain compared to body size, which is highly dependent upon glucose metabolism. Thus, infants show an earlier activation of fatty acid oxidation. Secondly, infants have a large ratio of surface area to body mass. And this requires high basal energy demands to maintain body temperature, which is dependent on shivering thermogenesis, which is entirely dependent upon the fatty acid oxidation pathway. And thirdly, there's a lower activity of several key enzymes in fatty acid oxidation. For example, the biosynthesis of carnitine is only 18% of adult levels in the infant. The estimated prevalence of this group of disorders is probably much greater than 1 in 5,000, because every month new statistics appear as there's a higher clinical index of suspicion, as well as with newborn screening that is inclusive of this group of disorders. During times of fasting stress, shivering thermogenesis, infection, mild to moderate prolonged exercise, and emotional stress with catecholamine-induced lipolysis, one can have acute catabolic decompensations. So one may have hypoketotic hypoglycemia with encephalopathy and seizures. In the long chain defects, there tends to be a hypertrophic cardiomyopathy with heart failure and arrhythmias, as well as progressive limb girdle lipid storage myopathy, exercise intolerance on mild to moderate prolonged exercise, which is fatty acid oxidation dependent, and recurrent episodes of muscle breakdown or myoglobinuria. There can also be a fatty liver with hepatomegaly and liver dysfunction during acute episodes, but liver dysfunction is persistent in VLCAD, or very long-chain acyl-CoA dehydrogenase, and in LCHAD, or long-chain L3-hydroxyacyl-CoA dehydrogenase deficiencies. There may be renal tubular acidosis, as seen with CPT1 deficiency. Also, individuals can have intestinal dysmotility during an acute crisis with recurrent vomiting. And pancreatitis we have documented in CPT2 deficiency. In very severe defects, such as glutaric aciduria type 2 or multiple acyl-CoA dehydrogenase deficiency, as well as with severe neonatal CPT2 deficiency, there can be intrauterine abnormalities, such as brain malformations and microcephaly. Now, there are two other symptom signs that we see only in LCHAD deficiency. So LCHAD deficient patients can also develop a pigmentary retinopathy, as well as a progressive sensory motor axonopathy. And mothers who are carrying infants who are affected with LCHAD deficiency can manifest with HELP syndrome or acute fatty liver of pregnancy. Now, the biochemical signature of this group of disorders is hypoketotic hypoglycemia, at which time critical blood work will show an elevation in the serum pre-fatty acid to ketone ratio of greater than 2 to 1. Normally, it should be a 1 to 1 ratio. So back in the 1980s, there was an epidemic of a very severe encephalopathy in young children known as Reye syndrome. At this time, Dr. DeVivo, through very careful clinical observation and biochemical profiling, identified this to be a toxic insult to mitochondria, as one might see with a drug ingestion or with inborn errors of metabolism affecting organic acids, urea cycle, or carbohydrate metabolism. He further suggested that the primary problem in terms of the brain was that there was substrate inavailability, which then led to the massive cytotoxic cerebral edema. And he cautioned against the use of aspirin because there seemed to be some association of aspirin in children with Reye syndrome as a precipitant. And this led to a change in practice and a marked reduction in the prevalence. So how do we put this together? So we have mitochondria with a toxic insult leading to dysfunction. At the time period in history, there were also two other factors going on. There was an influenza B virus epidemic, and this was shown to inhibit long-chain fatty acid oxidation. The administration of aspirin was shown by Doris Trauner in a mouse model to also inhibit long-chain fatty acid oxidation. So here we have two factors coming together. And we suggested that individuals who had a single episode of Reye syndrome were likely heterozygous for an inborn error of metabolism. So previously asymptomatic, and then with heterozygosity in these two factors, developed this severe encephalopathy. Those individuals who had recurrent Reye syndrome were actually children who had disorders of fatty acid oxidation or urea cycle defects. So this is the fatty liver that they had. So you can see the microvesicular steatosis with central nuclei in this toluidine blue stain. They had massive cerebral swelling, which often required decompression craniectomy to prevent herniation. And their biochemical profile was hypoketotic hypoglycemia with lactic acidosis, hyperammonemia, and a marked elevation in acyl-CoAs. So a central role player in fatty acid oxidation is this molecule carnitine, beta-hydroxy gamma trimethylaminobutyric acid. So here you see the trimethylamino group, the carboxyl group, and this beta-hydroxy group to which fatty acids and various drugs can esterify. So carnitine is essential for the transfer of long-chain fatty acids into the mitochondrial matrix for oxidation. It also shuttles acyl moieties between mitochondria and peroxisomes, and it acts as a kind of metabolic mop to acylate carnitine to remove toxic acyl-CoA metabolites, which may impair a number of bioenergetic cycles. But perhaps most importantly is the modulation of the acyl-CoA free CoA ratio in mammalian cells. By forming an acyl carnitine, it liberates CoA, which is required for a number of bioenergetic cycles, as CoA cannot move across intracellular boundaries. In carnivores, 75% of carnitine comes from red meat and dairy products. And the rest, 25%, comes from endogenous biosynthesis by a 6-step process that occurs in all tissues up until the 6th step, which can only occur in liver, kidney, and brain. That is where carnitine is finally manufactured. It is then exported into the bloodstream and taken up into all the remaining tissues by a high-affinity plasma membrane carnitine transporter. So millimolar amounts of carnitine are found in these products and micromolar amounts in avocados, which is the richest vegetable in carnitine, but it's only micromolar amounts. In vegans, the carnitine biosynthesis pathway is upregulated. Now, how do we investigate these disorders? So the most helpful investigations are the serum carnitine total and free. And in the case of those distal intramitochondrial beta oxidation defects, you will see an increased bound or esterified fraction. Very useful are the serum acyl carnitines because these can tell you if it's a short, medium, or long chain defect, and also what the species type is. Is it an acyl-CoA, an enoyl-CoA, an L3-hydroxyacyl-CoA, or is it a 3-ketoacyl-CoA? So this will give you an idea of which step in intramitochondrial beta oxidation you may be dealing with. Urine organic acids may provide important information also. In terms of the next tier of investigations, provocative studies may include fasting studies, which are helpful to demonstrate the fasting ability of the individual, but must be done under carefully controlled, carefully observed, almost ICU conditions in which the individual is following the child's biochemical profile very closely because it can actually precipitate a catabolic crisis. Safer would be carnitine loading tests or one can study oxidation in fibroblasts as well as acylcarnitine profiles in fibroblasts that have been taken from a skin biopsy. Once we have all this information in hand, then specific enzyme assays can be done in the affected tissue, followed by molecular mutation analysis. Now, nowadays, we have gene panels for fatty acid oxidation enzymes, as well as whole exome sequencing is also another modality for detection. However, that is fine if one finds pathogenic variants in a suspected gene that correlates with a phenotype. However, when we are hit with a tsunami of variants of uncertain significance, then one has to go back to the beginning and do careful clinical phenotyping, biochemical phenotyping, and enzyme assay to confirm whether that variant is indeed pathogenic or not. So improving diagnosis of fatty acid oxidation disorders before 1990, it was really only symptomatic patients that were being investigated with free and total carnitine and urine organic acids. Fluxomic studies were done in fibroblasts or lymphocytes just to look at flux through the pathway. And then specific enzyme assays were done. In the 1990s, with the advent of acylcarnitines identified by tandem mass spectrometry, as developed by David Millington, this was a giant leap forward. However, I should caution you that it is very possible to have false negatives if the blood sample is collected at a distance from the decompensation or if the individual is in a fed state. The second revolution in diagnosis came with molecular genetic testing, with high throughput methods such as whole exome and whole genome sequencing. Most countries now are developing newborn screening programs, so it's doubled the rate of detection. But again, newborn screening can miss diagnoses, and some patients are symptomatic before the results of newborn screening are available. So what has been the impact of newborn screening? So Bridget Wilkin in Australia looked very carefully at their data pre and post initiation of a newborn screening program and found there was a significant reduction in morbidity and mortality in MCAD and long-chain fatty acid oxidation defects. And just to give you an example, MCAD deficiency, which is the most common fatty acid oxidation disorder, had a risk of death in the first 72 hours of about 4% and a further 7% fatality rate by 6 years, so 11% by 6 years of age. However, when individuals are now diagnosed early and appropriate treatment and preventative measures are instituted, they have a very good outlook and very low morbidity. In the very severe disorders like neonatal onset trifunctional protein or LCHAT deficiency, or in severe CPT2 or carnitine acylcarnitine translocase deficiencies, there's still a high neonatal mortality rate. But the most, I think, brilliant example of how early intervention makes such an impact is the high affinity plasmalemmal carnitine transporter defect, OCTIN2 deficiency, which was formerly uniformly a lethal autosomal recessive disorder with death in the first few years of life. And now with early diagnosis and institution of high-dose oral L-carnitine supplementation, these individuals are living into their late adulthood years with a good quality of life. So there are now a number of molecular genetic testing programs that are being investigated in the UK, in Belgium, and the US. And the advantage here is that it allows for many disease-causing genes in a single assay. But again, if one gets variants of uncertain significance, it's very important to do careful clinical and biochemical phenotyping. So what are the pathophysiologic mechanisms of toxicity in this group of disorders? So for all of them, it's an insufficient production of ATP to meet the bioenergetic needs of different tissues. In the short and medium chain disorders, with the accumulation of short and medium chain acyl-CoA metabolites, we know that these can impair the Krebs cycle by inhibiting citrate synthase, beta oxidation itself, gluconeogenesis by inhibiting pyruvate carboxylase, and the urea cycle by inhibiting carbamyl phosphate synthetase. In the long chain defects, we have additional mechanisms. So long chain acyl-CoAs become long chain acyl-carnitines, which are essentially detergents and which cause a disruption of plasmalemmal and mitochondrial membranes and potentiate free radical mediated lipid membrane peroxidative injury. And this is likely the mechanism for the myoglobinuria. Also, long-chain acylcarnitines may activate calcium channels in cardiac and smooth muscle myocytes, and thereby can be associated with arrhythmogenesis. So these are the disorders that our research team has worked on over the years. And as I said, I'll be talking about the high-affinity carnitine transporter, SCAD, and LCHAD, or trifunctional protein deficiency specifically, and then conclude with an overall plan for the treatment of this group of disorders, as well as the current new possible treatments. So everything starts with a single patient, and this was the first patient that we investigated. So she was a 9-year-old girl born of unrelated asymptomatic parents. Her sister had developed cardiomyopathy at 1 year of age, failure to thrive, and then sadly died by 3.5 in end-stage cardiac failure without a diagnosis. Our index patient was noted to have a cardiac murmur at 1 month of age. She fortunately suffered no episodes of hypoketotic hypoglycemia, but developed gross motor delay and progressive weakness with failure to thrive. By 3 years, she had end-stage cardiomyopathy despite all anti-failure medications, and her EKG showed markedly peaked T waves. At 4, her serum and muscle biopsy were sent to Dr. DiMauro's lab at Columbia University, who diagnosed her to have very low carnitine concentrations. The muscle biopsy showed the characteristic lipid storage, but all her beta oxidation enzymes, intramitochondrial enzymes, were normal. And she also didn't have the characteristic dicarboxylic aciduria that one sees with intramitochondrial beta oxidation defects. But what she did have was a marked renal reabsorptive defect of carnitine. So the transporter also sits in the kidney, and the kidney normally reabsorbs 95% of the filtered load. So this was then the first sign of a carnitine transporter defect. She was started at 4 on high-dose oral carnitine supplementation at 100 milligrams per kilogram per day, divided QID. And in the first week, her father noted that it seemed like a light bulb had been turned on, that his daughter's affect improved so much, her appetite increased. By 1 month, she was gaining weight. She had marked improvement in exercise tolerance, and those peak T waves had inverted. By 4 months, she had excellent exercise and exercise tolerance, and her cardiac volumes were decreasing. By 5 years, she regained all her gross motor milestones. At 6.5, her digoxin and diuretic could be discontinued. At 9, she had a serum carnitine that was borderline low. It was markedly improved from her prior carnitine levels. However, with the transporter defect in the kidney, there is generally low normal carnitine with treatment. Her IQ was excellent, and she was a competitive swimmer. Ultimately, she went to university, obtained a degree in economics, and played competitive basketball. Now, had she not been diagnosed, she would have suffered the same fate as her sister. So this is one of those truly highly treatable conditions that must not be missed. So this is the dramatic graph showing her left ventricular end systolic and end diastolic volumes plotted against months of carnitine therapy. And you can see that by 7 months, her cardiac volumes are coming into the normative range. Here you can see the dilated heart and the improved cardiac silhouette and the inversion of the formerly peaked T waves. So we set up an assay in cultured skin fibroblasts. This was part of my postdoc, and we measured carnitine uptake here on the y-axis against increasing extracellular carnitine concentrations. And this is the normal control population up here. This is the uptake in our affected patient, which was about 2% of controls, which it is in many of the children. And these are the 50% uptake we demonstrated in her obligate heterozygote parents. So you can see from here that the concentration gradient between the plasma and tissues is enormous. And this requires the high affinity transporter, which is ubiquitous and expressed in all tissues. So in brain, it's 5-fold, heart, muscle, and liver, 50-fold, and in sperm, 2,000-fold. Serum concentrations are usually in the range of about 40 to 50 micromoles per liter, and these are tightly maintained by the renal threshold, where 95% of the filtered load is generally reabsorbed. So just to summarize, all patients with cardiomyopathy and weakness and episodic hypoketotic hypoglycemia respond to high-dose L-carnitine treatment. There's dramatic improvement in symptoms within a few weeks and reduction of heart size toward normal within a few months, provided individuals are compliant with therapy. And the plasma carnitine concentrations approach the normal range, but are rarely elevated because of the renal reabsorptive defect. So basically, this transporter defect we have identified throughout the world. It's particularly highly expressed in areas of high consanguinity, and the highest is 1 in 300 in the Faroe Islands off the coast of Iceland. So this is our predicted protein structure of the carnitine transport based on motif analysis of the amino acid sequence with 12 transmembrane domains, 5 protein kinase C and 1 protein kinase A phosphorylation site, and an ATP binding domain. The transporter also depends on the sodium gradient. We were bases away from cloning the gene when it was published, but we had our primers ready and we were able to identify the first mutations in the carnitine transporter defect. This is my research associate of many years, wonderful Dr. Anne-Marie Lamhonwa, with whom we performed these molecular studies. We were fortunate to receive referrals from throughout the world with children suspected to have the carnitine transporter defect. And we tried to correlate the residual activity, severity of the mutation with the clinical presentation, but found that there really was not a good genotype-phenotype correlation. And we concluded that the age of presentation and type of presentation depended very much on exogenous precipitants. We also found in one family that had 3 affected children, in the 3rd child who was proactively diagnosed right from birth and was started right away on high-dose carnitine therapy, they never even developed the phenotype, which again speaks to the importance of early diagnosis. So this is a summary of some of the mutations we demonstrated. So there were missense, loss of function mutations, deletions, insertions, splice site mutations, so there was no common mutation. So I have a few cautionary lessons regarding molecular studies and newborn screening. So we recently described a large kindred in Canada of 3 generations, where there were 4 affected subjects who had very low blood carnitine and 6% fibroblast carnitine uptake, but they were negative on whole exome sequencing. And it was only subsequently on a next generation sequencing panel that they were found to have homozygosity for a 5' UTR pathogenic variant. So it highlights that one has to look at this region also. Also, there can be intronic mutations. Further, 3 infants who had very low blood spot carnitine were actually found to be unaffected and were thus false positives. And the reason they had such low blood carnitine was that their mothers, who were sisters, were affected and had very low blood carnitine. Furthermore, 2 affected infants born to a heterozygous sister and affected father were false negatives on newborn screening, likely because their heterozygous mother had relatively higher carnitine concentrations. And they were picked up based on their increased urinary fractional excretion of free carnitine, which proved to be the most sensitive test. So again, underlying where functional studies may be more informative. In a large series of 140 patients with primary carnitine deficiency and less than 20% of normal of carnitine transport, all of these individuals were sequenced for their 10 exons and the flanking regions of the SLC22A5 gene that encodes the transporter, and 16% of alleles causing primary carnitine deficiency did not have mutations in the coding regions. So again, they may have been intronic mutations. So it was concluded that the functional studies in fibroblasts may still remain the best strategy for diagnosis. Now, we were interested in further studying the transporter, so we made a green fluorescent protein octin-2 cDNA and transfected it into mutant lymphoblasts. And you can see the expression of the transporter. And using confocal laser scanning microscopy, we did indeed confirm its localization to the plasma membrane. Similarly here on bright field microscopy, we showed it in mutant lymphocytes following transfection. And here you can appreciate that these untransfected blue bars show marked increase in carnitine uptake following transfection, thereby confirming the identity of the cDNA. Now, I should also like to emphasize that octin-2 transports many other drugs other than carnitine, and perhaps most notably for our population, valproic acid. So in 1991, Yehuda Shapira and Elisa Gutman studied a group of children who were on long-term valproate therapy and found them to have low muscle carnitine concentration. So we became very interested in understanding the mechanism. And this was my postdoc, Dr. Zhongwei Xie, who performed a majority of these studies. So we basically incubated normal control fibroblasts at 3 carnitine substrate concentrations, 50 micromolar to simulate the normal physiologic concentration, 20 micromolar for the secondary deficiency range, and 5 micromolar for the primary deficiency range. We incubated them with increasing concentrations of valproate from subtherapeutic to toxic, and increasing period of valproate pre-incubation from 1 to 28 days. And this is just an example of some of our results. So here on the y-axis is carnitine uptake. Here is increasing concentrations of valproate. And going from left to right and bottom and top to bottom, we have increasing days of valproate inhibition. And we found that the degree of valproate inhibition of carnitine uptake was directly proportional to the duration of valproate pre-incubation and parallel for all 3 carnitine substrate concentrations. We then looked at the effect on the toxic dose, causing a 50% suppression of carnitine uptake. And we found that, and this is plotted against the days of valproate pre-incubation. So the maximum effect of valproate pre-incubation time on carnitine uptake for all 3 carnitine concentrations was achieved by 10 to 14 days of valproate exposure, beyond which there was no further significant additional effect. And you will note that the toxic dose 50% was reached by about 450 micromolar of valproic acid concentration, which is the usual mid-therapeutic range. And this fit in very well with the idea that when children who are, let's say, predisposed for a number of reasons for carnitine deficiency, how they are at increased risk for valproate hepatotoxicity, and how this generally occurs within the first 2 to 3 months of therapy. And this would give enough time for steady state concentrations of valproate to be reached, and for this 2 weeks of maximum toxic effect to occur, and then to lead to progressive tissue carnitine depletion. We also found that the inhibitory effect was reversible following greater than 5 days of valproate-free growth, and that the maximal inhibitory effect was reached much earlier by 3 days in fibroblasts from heterozygotes for the octin-2 defect. So how did we put this together as a model for valproic acid hepatotoxicity, which has an incidence of 1 in 5 to 1 in 10,000 in adults, but increases dramatically to 1 in 500 for infants less than 2 who have a chronic neurologic disorder who are on multiple anti-epileptic drugs. So we might suppose that the presentation of seizures could be a symptom of an inborn error of metabolism. Each of these have their own mechanisms for carnitine deficiency. A child under 2 years of age, especially one with failure to thrive, would have decreased carnitine stores, as 90% of carnitine is stored in muscle. If their intake is impaired because of malabsorption or a carnitine poor diet, this would further add to their carnitine deficiency. Furthermore, at a young age, as I mentioned before, there's a decrease in the carnitine biosynthesis rate, and this would be further impaired by renal or liver disease where the final biosynthetic step occurs. Then if other anti-epileptic drugs are included, these can be synergistic with valproic acid. So then if we add valproic acid into this mix, we know now that it inhibits carnitine uptake at the high affinity carnitine transporter, likely by the formation of valproyl carnitine esters, which compete with free carnitine at the renal threshold, leading to free carnitine loss. With carnitine deficiency, there would be an inhibition of long-chain fatty acid oxidation. Valproic acid is also a medium-chain fatty acid, so it can inhibit MCAD. Furthermore, formation of valproic-CoA esters with sequestration of free CoA would limit beta oxidation. And we know that valproate metabolites, the 2,4-diene metabolites, are hepatotoxic, and that valproate also inhibits carbamyl phosphate synthase, leading to hyperammonemia. So here we have a scenario where you have a child at high risk for valproic acid hepatotoxicity. If this is detected, this child must go immediately to the ICU for high-dose intravenous L-carnitine therapy to try to rescue the cells, and then should be investigated very thoroughly for an underlying inborn error of metabolism. And I would go so far as to say that any child who's being considered for valproate therapy, it is important to carefully, clinically, and biochemically phenotype them to try to reassure oneself that there is no suggestive evidence for an underlying inborn error of metabolism. We know that children with polymerase gamma deficiency are particularly at risk. Now, we've done a huge number of studies to characterize octin-2, octin-1, and we discovered a new human protein, octin-3. And I'm just going to give you the final results here. I won't show you all of the experimental data, but octin-2 we've identified as a high affinity plasma level carnitine transporter, octin-1 as a low affinity mitochondrial transporter, and octin-3 as an intermediate affinity peroxisomal carnitine transporter. And these supply a multitude of lipid synthetic and breakdown pathways. And again, the critical role here, we believe, is keeping the acyl-CoA free CoA pool constant even under conditions of high turnover. So we generated very specific transporter-specific antibodies to octin-1, 2, and 3, and looked at murine, brain, heart, and mammary gland. And this is just a couple of examples. So this is cerebellum H&E stain. And we used a secondary antibody with a DAB peroxidase system that stained the transporter brown. So this is octin-1, this is octin-2, this is octin-3. And you can see that they're highly expressed in the cerebellar Purkinje cells. And this is in the choroid plexus 1, 2, and 3. And octin-2 is especially highly expressed, which is probably important for the transport of organic cationic drugs. And we also showed high expression in the motor cortex, the arcuate nucleus of the thalamus, the cornuamanus of the dentate gyrus, ascending and descending pathways of the spinal cord, and in the olfactory bulb. And it was suggestive of roles in modulating cerebral bioenergetics and in acetylcholine generation for all of the different functions that we know to be in these regions, and may help to explain some of the CNS abnormalities we see in the human condition. There's a huge literature on the role of L-carnitine and acetylcarnitine in the brain. Some of these relate to neuromodulation of dopamine, epinephrine, serotonin. Carnitine is also an inhibitor to GABA, and acetylcarnitine donates acetyl groups to choline acetyltransferase for cholinergic neurotransmission. So there are a number of key roles. Carnitine is also felt to be neuroprotective and work as an antioxidant. So we have our phenotype for octin-2. We suspect octin-1 will look similar, but octin-3, being a peroxisomal transporter and having very high expression in cerebellum and in anterior horn cells, we wonder whether there's a peroxisomal phenotype out there. So now I would want to take you into the very complex story of SCAD deficiency. So this is where SCAD sits. It's the first short-chain acyl-CoA dehydrogenase step. So these children, this has been a controversial entity. There are children with very severe presentations with neonatal onset, early mortality. They tend not to have hypoketotic hypoglycemia because they can metabolize long and medium chain fatty acids to make ketones, but they have central nervous system abnormalities with seizures, developmental delay, hyperactivity, microcephaly, progressive myopathy, and episodes of metabolic acidosis. So this is the very severe phenotype. But this CNS presentation implies that their mechanism must be related to short-chain fatty acid neurotoxicity because they tend not to have these hypoketotic hypoglycemic episodes. So we're very interested in this mechanism. And then there are children who have ethylmalonic aciduria, which is the biomarker for this disorder, because they carry variants that have this association, but have no symptoms. So we were intrigued and wanted to find an explanation for this. So our index case was a 10-year-old girl who was referred to us on her second metabolic decompensation. So basically she was born with hypotonia and then developed progressive limb girdle myopathy, ended up with marked contractures and scoliosis, and was wheelchair dependent by 5 years of age. And at ages 8 and 10 had 2 acute decompensations and ended up in the ICU on a ventilator. So on the second episode, we were consulted and we performed metabolic profiling and found her to have marked ethylmalonic aciduria. She also had elevated butyryl carnitines in her serum, suggesting a defect in the SCAD enzyme. We then measured her SCAD activity and found her to have 0% activity with the ETF reduction assay and MCAD antibody, and to be CRIM negative. And on molecular mutation analysis, she had a pathogenic homozygosity for this 319C to T variant. What was striking in her were 2 additional features of cardiomyopathy and cataracts, which resembled the complex 1 deficiency Singer's phenotype that had been studied by Dr. Brian Robinson's lab. And in this group of patients, he had demonstrated a marked increase in plasma aldehydes, suggesting free radical toxicity. So we measured these same aldehydes in our index case and found them to be similar. On the basis of this finding, we then instituted a 6-month trial of antioxidants, just vitamin E and vitamin C. And at the end of 6 months, she had a 6-fold increase in her deltoid endurance. We were then interested in learning more about this particular variant, and through our collaborators around the world, we were able to identify 10 children, 7 male, 3 female. 3 were homozygous for this pathogenic variant, 7 were heterozygous for the variant, and also this common variant that has the association of ethylmalonic aciduria. And the striking features, again, were hypotonia, developmental delay. About 50% had myopathy, but they all had this biomarker of ethylmalonic aciduria and methylsuccinic aciduria. So studying this group, we concluded that the wide clinical and biochemical phenotype suggested a multifactorial polygenic condition that should be screened for in individuals with myopathy and EMA. So our collaborators in Denmark, Niels Gregerson's group, had done beautiful mitochondrial biogenesis experiments looking at this particular mutation, and found that this particular mutation made the protein unstable and unable to form the usual tetrameric SCAD enzyme. It was also thermolabile and led to this very severe folding defect. In terms of possible pathogenetic mechanisms in SCAD deficiency, we suggested the following: that there was increased oxidative stress, because we know that ethylmalonic acid is neurotoxic. It inhibits mitochondrial CK, increases lipid and protein peroxidation products, decreases glutathione levels, and inhibits complexes 1, 3, and 4. We also know that SCAD protein has a tendency, if mutant, to misfold, and this can produce reactive oxygen species, because and defect in the SCAD function due to protein misfolding can cause problems with the interaction with electron transfer flavoprotein, and this can be a site for excessive production of reactive oxygen species. Interestingly, also a certain group of our patients had reduced antioxidant status, in that they had reduced manganese superoxide dismutase protein and mRNA, but no sequencing defects. So it suggested some intrinsic dysregulation of SOD2. And butyric acid, we know, can alter gene expression. So we were interested in studying the mechanism in vitro in cultured skin fibroblasts, and this is Dr. Zuela Zolkipley, who was my postdoc who performed these studies. We looked at 17 SCAD deficient patient fibroblasts, 7 with mitochondrial trifunctional protein or LCHAD deficiency, 5 with CPT2 deficiency, and 4 with MCAD deficiency, and asymptomatic controls. And what we did was we incubated the cells with menadione, which is a free radical amplifier, and we incubated them under 4 conditions: normoglycemia, normothermia, hypoglycemia, hyperthermia, and hypoglycemia and hyperthermia. And we measured time to 100% cell death, as shown by trypan blue dye exclusion. And here we have our cell lines SCAD, our long chain defects, MCAD, and controls, and the black bars are the controls. And you will note that there is marked toxicity. So this is hours to 100% cell death. So there's a marked toxicity in our SCAD deficient and long chain fatty acid oxidation deficient cell lines. MCAD seemed to be very robust even compared to the controls. And as we proceed to hypoglycemia, hyperthermia, and hypoglycemia, hyperthermia, this becomes progressively more severe. So into this situation, we then wanted to see how we could intervene. So we used different therapeutic agents, vitamin C and E as a free radical neutralizers, N-acetylcysteine, which has raw scavenging actions, but is also a precursor for glutathione, and bezafibrate, which is a PPAR agonist that increases complexes 1, 3, 4, which I've told you are decreased by ethylmalonic aciduria. And here we have again cell lines, and you will note that with N-acetylcysteine, the SCAD and the long chain defects show a 7-fold increase in longevity. MCAD also shows some increase, but not to the same degree. So this was a really marked saving effect by N-acetylcysteine. And then again, I'm showing you just examples. Here we looked at all our SCAD deficient cells with bezafibrate, antioxidants, vitamin C and E, and N-acetylcysteine, and clearly N-acetylcysteine had the greatest effect. So our conclusions were that the vulnerability to oxidative stress in SCAD and CPT2 and mitochondrial trifunctional protein was multifactorial and exacerbated by hyperthermia and hypoglycemia, but hyperthermia was a more significant risk factor, likely because it led to protein misfolding. The rescue with glucose and normothermia was effective if instituted early enough in the catabolic crisis. And interestingly, vulnerability to oxidative stress was independent of genotypic severity. SCAD and long-chain deficient fibroblasts were most vulnerable to menadione-induced oxidative stress, suggesting that they had higher levels of ROS. And we showed, as I mentioned before, that the greatest effect was found with N-acetylcysteine. So how did we put this together? So we thought that individuals with SCAD spectrum may remain asymptomatic until they're exposed to a triggering illness. Hyperthermia with infection is a frequent trigger for all FAO defects, but in SCAD, this would lead to protein misfolding and aggregation and ROS production. Oxidative stress under heat stress has also been shown to impair the heat stress response, delaying the unfolded protein recovery. And finally, individuals with any downregulation of antioxidant mechanisms would be more vulnerable. So we suggested that the resulting oxidative imbalance may exceed a subclinical threshold in affected individuals, leading to clinical disease. And these were some of the treatment strategies we recommended. I'll just go to our trifunctional protein deficiency case. So trifunctional protein covers steps 2, 3, and 4. So 4 alpha subunits encoding 2 and 3, and 4 subunits encoding step 4. So this is LCHAD here. Some patients only have LCHAD isolated deficiency, others have trifunctional protein deficiency, which tends to be more severe. So again, in our index case, everything starts with a single case. Our boy was born to first cousin parents. He had gross motor delay. At 20 months, he started having recurrent myoglobinuria. He had 8 to 10 episodes a year. At 4 years, the triceps biopsy showed some type 1 fiber predominance, and he had a slowly progressive limb girdle myopathy. But what was very unique was this symmetric polyneuropathy as well as some facial weakness and ptosis. At 7 years, an ECG showed mild intraventricular conduction delays, but normal echo. And a triceps biopsy repeated at this time showed mild increased lipid. Nerve conduction showed progressive sensory motor axonopathy with secondary demyelination. A lab results showed increased in his esterified carnitine bound fraction. Serum acylcarnitine showed increased long-chain L3-hydroxyacylcarnitines. Urine organic acid showed 3-hydroxydicarboxylic aciduria, and cultured skin fibroblasts and muscle biopsy showed him to be LCHAD deficient. We actually diagnosed him in the opposite order here because his biomarkers were consistently negative. So this is where you have to have tenacity of investigation. At 7 years, we started him on all the standard fatty acid oxidation therapies, and we almost completely reduced his episodes of myoglobinuria. He had one further episode over the course of 8 years, but we had no impact on his power or endurance. And again, thinking about underlying pathophysiology, long-chain L3-hydroxyacylcarnitines are membranotoxic and cause membrane peroxidative injury and disruption. And given that other myopathies with membrane disruption issues were being treated with prednisone, such as Duchenne dystrophy, we instituted a trial of prednisone, well, deflazacort therapy in the same doses being used in the Duchenne boys. And within a month, he had complete restoration of limb girdle power. He could rise from the floor in 3 seconds. He increased his maximum walking distance 13-fold. And he could climb 20 steps in 30 seconds from the former 2. And we also, in the beginning, before starting steroids, we had him walk just a distance of 10 yards. And while sitting at the beginning, his CK was 50. And after walking a distance of 10 yards, his CK was 2000. So he clearly had very fragile and leaky muscle membranes. We then tapered his prednisone to the minimum dose that sustained his limb girdle power until he was 18 years of age and left to go to the adult side. And there was some transient increase in nerve conductions, and he had no significant adverse effects. Now, at this time, DHA deficiency, docosahexaenoic acid, which is a very long chain omega-3 polyunsaturated fatty acid, was being documented as being deficient in the plasma and red cell membranes of children with LCHAD and retinal dysfunction. As I mentioned before, they can get pigmentary retinopathy. And there are a number of possible etiologies, namely the high carbohydrate, low fat diet can sometimes lead to essential fatty acid deficiency. And we thought about other mechanisms. At any rate, at 11 years of age, he had progression of his sensory motor axonopathy with wrist drop and foot drop and claw hand deformity. His hands were almost unusable at that time. And at that time, there were no purified forms of docosahexaenoic acid. So we obtained a cod liver oil extract, measured the amount of DHA, and put him on a trial for 20 months. And he recovered entirely the power in his hands. He also had a marked improvement in his foot drop. His maximum handwriting endurance went from 2 lines to 2 pages, and his maximum walking endurance increased by 2.5-fold. And here you can see on nerve conduction how he had an 18-fold increase in axonal amplitudes in his median and 7-fold increase in his ulnar nerves, and restoration of conduction velocities. And in posterior tibial and peroneal nerves, these were absent and they reappeared, and his conduction velocities almost returned to normal. So just in the last 2 minutes, I guess, general principles of treatment in fatty acid oxidation disorders. First, avoidance of precipitating factors, very, very important. So if a child develops vomiting and they're unable to keep anything down, they must go immediately to the emergency room for intravenous glucose because the more that the acute stress on the fatty acid oxidation pathway continues, the more deleterious the situation can become and then lead to a catabolic crisis. So acutely, they must receive glucose at 8 to 10 milligrams per kilogram per minute. Excuse me, just turn that off. In the chronic situation, They should be on a high carbohydrate, low fat, frequent feeding diet. And it is very important to supplement with essential fatty acids. In children who are very, let's say, vulnerable or fragile in the early mornings with symptoms of early morning hypoglycemia, one can also consider uncooked cornstarch as a nighttime dose, a single dose, which then releases slow glucose over the course of the evening and decreases overnight fasting time. However, this can also put on weight, which is not good for children with neuromuscular disorders. In the long-chain fatty acid oxidation disorders, one can consider medium-chain triglyceride oil because it gets under the block. We haven't personally found it to be useful. Riboflavin for multiple acyl-CoA dehydrogenase deficiency due to ETF or ETF dehydrogenase deficiency. And L-carnitine supplementation, absolutely critical, essential, life-saving for the high-affinity carnitine transporter defect. It hasn't really been proven of value in short and medium chain defects, and I will highlight here, very importantly, it can be deleterious in long-chain fatty acid oxidation defects, especially if given in the acute situations, because long-chain acyl-CoAs become long-chain nasal carnitines, become membranotoxic and arrhythmogenic. Now, there was a consensus panel European workshop that covered experience with 75 patients with VLCAD or trifunctional protein deficiency from 18 centers. And they made recommendations in terms of suggested maximum fasting periods when children were metabolically stable. If children were unstable, the fasting time should be even shorter. They also made recommendations in terms of the amount of fat restriction, so 25 to 30% in VLCAD and trifunctional protein deficiency. And again, it's very important to supplement with essential fatty acids to prevent deficiency states. In VLCAD for exertional muscle pain and weakness, one can consider MCT or carbohydrate load prior to exercise. And in trifunctional protein deficiency, it is very important to get the dietary restrictions in place as soon as possible because of the high mortality in the first few days of life. Based on our studies, now DHA supplementation in trifunctional protein LCHAD deficiency is a standard of care. Tentative treatments. So people are wondering about peroxisome proliferated activated receptor agonists, PPAR agonists, which can upregulate fatty acid oxidation. So bezafibrate, which is one we used in culture, resveratrol, and there are trials being done with this REN-001 at the present time in the United States. Bezafibrate, I'll just present some of the data that's come out in vitro and in basically in empiric trials. So in myoblasts and fibroblasts with mild CPT2 and mild VLCAD deficiency, Jawadi and Bestan showed an upregulation in long-chain fatty acid oxidation, but it did not work in very severe enzyme defects where there was no enzyme to be upregulated. In a 6-month trial of bezafibrate in 6 CPT2 deficient patients and followed for 3 years, Jean-Paul Bonfont showed that there was an increase in palmitate oxidation, increased physical activity, and a decrease in myoglobinuria and muscle pain. And similarly, another empiric trial by Yamaguchi in a 2-year-old with intermediate form of GA2, he showed improvement in motor and cognitive skills. But these were not RCTs. Now, there was a 3-month randomized double-blind crossover study of bezafibrate in adults with CPT2 and VLCAD deficiency that did not show a significant improvement in palmitate oxidation or change in heart rate. However, this was a very small group of patients over a short period of time. And it has also been used in trifunctional protein deficiency by Suyama, and he has shown a reduction in the myoglobinuric episodes in 2 patients. One caution, I should say, is that bezafibrate is a hypolipidemic agent. Therefore, you must monitor CK for bezafibrate-induced myoglobinuria. It's rare. And this molecule, I would really like to just touch on triheptanoin. This is an anaplerotic odd-chain triglyceride that's broken down into 2 fragments of acetyl-CoA and 1 of propionyl-CoA, both of which can go into the Krebs cycle. So this is anaplerotic, and it generates ATP in reducing equivalents. So there's been quite a bit of work in VLCAD, CPT2 deficiency, and other long-chain defects. And the the overall feeling is that it does seem to improve the myalgia, the myoglobinuria, and the cardiomyopathy. And there's been only one RCT in 16 long-chain fatty acid oxidation defects where it was shown to decrease left ventricular mass and increase ejection fraction. So very interesting molecule. Potential future directions are direct ketone supplementation. Now, these are all future directions. Chaperone therapy for misfolded proteins, etomoxir to inhibit CPT1 activity to decrease long-chain entry into the mitochondria and very severe defects, mitochondria-targeted electron and ROS scavengers, and other medium-odd branch-chain fatty acids. And future therapies may involve gene therapy. To this point in time has only been done in fibroblasts and in mouse models and has shown success in those systems. There are no clinical trials. So to conclude, I would like to leave you with these thoughts. If one can ascertain the impact of the block in metabolism, understand what alternate sources of fuel can be offered to generate ATP, such as glucose, what strategies can be used to bypass or circumvent a biochemical block, such as giving high-dose L-carnitine to the carnitine transporter defect, how one can remove toxic metabolites that may impair other bioenergetic pathways. So here we would have excessive ROS accumulation, as we see with SCAD deficiency, through the use of antioxidants. Stabilization of plasmalumal mitochondrial and synaptosomal membrane and long-chain defects, as we've done with docosahexaenoic acid, and provision of intermediary metabolites that replenish anaplerotic pathways, such as triheptanoin, and future pharmacologic therapies with PPA or agonists or chaperones. Just leave that. So my last thoughts are, these are important disorders. They're potentially rapidly fatal, major source of morbidity. Recognition early and prompt institution can have a dramatic effect on morbidity, mortality. They are often silent clinically and biochemically between catabolic episodes, and thus require a high index of suspicion and tenacity in investigation. They're far more common than previously recognized. And if we understand the underlying pathophysiologies, we can develop new precision medicine approaches. I thank you so much, and forgive me for going over time.
Thank you so much, Dr. Ingrid, for the wonderful lecture, as always. It was a great learning opportunity for all of us. So we'll take a few questions. In a child with suspected fatty acid oxidation defect who presents with an episodic encephalopathy and seizures, and also had a documented hypoketotic hypoglycemia, you're awaiting the clinical biochemical as well as the molecular diagnosis confirmation. So how should the clinician approach or plan the management?
Okay, I mean, if you have a strong suspicion of a fatty acid oxidation defect, which it sounds as though you do, I think it's very important, firstly, to put in place all the preventative measures. So we spend a lot of time counseling children as well as parents in terms of what signs to look out for and what to avoid. So number one, fasting needs to be avoided under all circumstances. So if it's, I showed those fasting periods in the infant, but in, let's say, a slightly older child, the high carbohydrate, low fat, frequent feeding diet. So I would say 3 meals a day and 3 intermeal snacks, and especially important, the bedtime snack, because that will give them some, energy or calories over the course of the night and decrease their fasting time. Number two, I would say that if a child develops an infection, then rapid control of fever and prompt treatment of infection is very important, because we know with infection there are several stressors. Number one, they may be vomiting, so that leads to fasting. Number two, they can be shivering, and that stresses the fatty acid oxidation pathway. And number three, for some reason, the body wants to use fatty acids rather than glucose during times of infection. So that's sort of a triple risk situation. Thirdly, they must avoid mild to moderate prolonged exercise. So in our clinic, we really want to keep these children as fit as possible. So they can do high intensity, short burst exercise because their glycogenolysis and glycolysis is intact. And so they can do isometric exercise and very short bursts of exercise. I usually say take a high carbohydrate snack, exercise for 15 minutes, stop, rest, take another high carbohydrate snack or drink, and then another 15 minutes, and that's it. Because fatty acid oxidation starts getting stressed as you're doing mild to moderate prolonged exercise. So you want to keep them in a zone where they can exercise safely without pushing themselves towards myoglobinuria or an acute metabolic decompensation. Also, one of the factors that's very difficult to control is emotional stress. So I had my LCHAD patient that I presented to you. He would have episodes of myoglobinuria when he was stressed with exams or with tense situations at school. But he would also have them when he was excited, like going to a birthday party, and he'd have an episode of myoglobinuria because he was just so excited. So we tried to advise the parents to try to divide up exciting activities in a way that were tolerable to him. So not too many exciting activities in one day. And then again, if one sees, and I have patients who will call me and say, I'm feeling very, anxious, or I'm feeling very trembly, which may be signs of hypoglycemia, or if they're getting a little encephalopathic or a little drowsy, then immediately to the emergency room for intravenous glucose therapy, because that then puts a halt on the stress on the fatty acid oxidation pathway and allows the situation to be reversed. And the sooner it's done, the more likely you're going to get a good outcome. The longer they go towards that catabolic cliff, it is harder to bring them back, and they may already be having myoglobinuria and cardiac arrhythmias, which again become very critical, life-threatening events. So I think that is really the first step, is that very careful advice in terms of preventative measures. And once people understand that, I think that they then become part of the clinical team that you have with the family. And I generally will also give them written instructions that they can have for themselves and also take to the emergency room, so that when they arrive in the emergency room, people know, what's the critical blood work we should be taking. So my critical blood work always is glucose, free fatty acid to ketone ratio, serum carnitine total and free, serum acylcarnitines, and then you may want to look at a lactate and ammonia also, and the venous gases, but that, and urine organic acids. So that can also help you then with the further diagnosis. And as I said, some of these disorders, that LCHAD deficient patient, I sent so many serum acylcarnitines for analysis, and they came back consistently normal. But I was convinced that he had LCHAD deficiency based on his clinical phenotype, because a case had been published before with recurrent myoglobinuria and the progressive sensory motor axonopathy by Bertini and Carlo Dionisi from Rome. And I thought, this is what the boy has. And so I was determined to make that diagnosis. And ultimately, I made the diagnosis by measuring myself his LCHAD activity in his cultured skin fibroblasts and in his muscle biopsy, made the diagnosis. And then finally, on the next episode, I was able to send off a serum acylcarnitine in the acute catabolic crisis, and we got the diagnosis. So I think putting in important preventative measures and really highlighting to parents and to the children themselves what symptoms need to be reported and what needs to be done in the acute situation is very important. And then
thank you so much, Professor Ingrid. It was so wonderful. Before Sangeeta and Vaishak ask some other questions, we have Professor I.C. Verma here, who actually was can be called as founder of genetics in India. He's currently in the US, so he's joined. So I would like his comments. He was there. Yeah, Professor Verma. Ma'am, we can't hear you.
You're muted. I'm not hearing.
He's not audible. Sir, you have to unmute yourself. Dr. Verma, you have to unmute yourself.
Can you hear me now?
Yes.
Loud and clear.
Okay. So I think, Ingrid, that was a very fascinating talk. I enjoyed it very much. You really made it very simple, very interesting. And I'm very happy that you've done such excellent work, which makes us, inspires us that we must also do something. I have just one question, which is related, but not directly related to your talk, that we often prescribe this mitochondrial cocktail. So what is your opinion about this mitochondrial cocktail, and what would you include in them?
Okay, so you mean for mitochondrial respiratory chain defects?
You know, there are many disorders which are not clearly mitochondrial, but we suspect they are. So we prescribe mitochondrial cocktail to benefit the patient.
Right.
So what is your practice? What is your practice?
Okay. So, well, first of all, I like to have my diagnosis firm. Is the clinical phenotype consistent? Like for mitochondrial disorders, we usually, do they have failure to thrive, sensory neural hearing loss, history of maternal pattern of transmission, migraine, etc., cognitive, intellectual disability. Then generally we will do, well, in the past we would do a muscle biopsy so that we could measure the respiratory chain enzymes. Now we actually have a panel with the Children's Hospital of Eastern Ontario, where we can look at 405 nuclear genes for mitochondrial disorders. And we also do mitochondrial DNA sequencing so that we can get pretty close to what the defect is or what the gene is. So the most common in our experience has been complex 1 deficiency. So what I generally do is I look at what the deficiency is and how can I bypass that block. So with complex 1, I like to try, I do in my clinic prospective crossover trials because I want to know, am I having an effect or not? And is it clinically significant, the effect? So I establish the baseline, the clinical, the biochemical baseline, quality of life. I do some exercise testing, and then I start on a combination. So if it's complex 1, I would try perhaps coenzyme Q10 or ubiquinol, because that bypasses complex 1, and vitamin C as an antioxidant also. CoQ also acts as an antioxidant because that would decrease reactive oxygen species, which we know occur with complex 1 deficiency if there's enzyme activity. And then I see them every 3 months. So I put them on and I see them at 3 months. And sometimes people say, oh, not sure, or, oh, it was an amazing difference. And then we go for another 3 months. So 6 months in total. And then I take them off. And then sometimes I get an urgent phone call saying, oh my goodness, my child is not behaving well or seems so tired and is unable to finish their homework. If they tell me this sort of thing, then I'll put them on again right away. But most of the time people will say, I'm not sure. So we go for 6 months off and then we put them on again for 6 months. And the end of it, I ask the parents and the child, these 3 periods, do they think that there was a positive effect or not? And if they say yes, definitely, then we continue. If they say no, we don't think there was any significant effect, then I may try some other combination. So this, I would say, would be my approach to a child with a milder phenotype. If they have a severe phenotype like Lay's disease, then I don't wait. Then I just put them on everything because they are at such high risk for severe metabolic decompensations. And I think we don't have any time to waste. And I'm not sure how much positive effect we have with it, but it's the one thing that we can do. So my combination there would include, again, CoQ10, vitamin C, oftentimes vitamin E, L-carnitine, thiamine, and riboflavin. So that would be the sort of combination of cofactors. And also I consider like alpha lipoic acid, which is a very good antioxidant. So in Lay's disease, because they really are very early in presentation, and because their phenotype is so severe, I try to give them every possibility of improved homeostasis within the mitochondria. But it's an empiric treatment. And I should say now that there are specific therapies that are coming out that are really promising, you know, so all the time new avenues are coming out. Some of them with these PPAR agonists like bezafibrate, which increases complexes 1, 3, and 4, as long as you've got some residual activity. Michio Hirano has done some amazing work giving nucleosides to children who have defects in nucleosides. So there's, I think, really promising developments happening in the mitochondrial world in terms of treatments.
So one other question, in India, it is more difficult to get the enzyme assays, biochemical tests. So is the DNA tests are easy to get. So are they enough? Or do we still need to do the biochemical?
Well, I would say that if you identify a gene that correlates with the clinical phenotype, and if you show the child to have known pathogenic variants that correlate with that phenotype, then that may be your final diagnosis. However, if you get, as we often do, a tsunami of variants of uncertain significance, then I think you have to go back. And I mean, we always have to clinically phenotype carefully, and we should always be looking at them biochemically. But then I think that's where the muscle biopsy and enzyme assay is very important. You know, to be able to prove, you know, that particular, let's say, gene encoding a subunit of a particular complex in the respiratory chain, that is the culprit.
Thank you so much. So you want to say something, sir?
No.
Dr. Verma, you were saying something?
No.
Okay. Thank you, sir.
Thank you. Thank you for joining, Dr. Verma. It's really a great honor.
He guides us and all, and he's there many of the sessions, and he's currently in the US with his
That's
son.
very nice. Oh, I should mention one other thing. You know, for MELAS, we have a very common mutation, the 324-3A to G mutation. And if someone has, like, for those mitochondrial DNA inherited disorders, blood white cells are not the best unless they have very high percentage of mutant heteroplasmy. And so that's where, you know, muscle becomes very helpful. But more recently, people have looked at urine epithelial cells for percentage. So muscle's a post-mitotic tissue, which is why it's the most informative, but urine epithelial cells are pretty close, and there's a pretty good correlation. So it's just another place one can look for, let's say, a particular mitochondrial DNA mutation.
You prefer it to the blood?
Yes, because the blood has such a high turnover rate that you can easily sort of through generational change the level of the actual mutant mitochondrial DNA may drop. It's informative when it's high, but if it's low, you may not get the diagnosis from white cells.
Thank you. Dr. Arijit, would you like to make some comments or ask something?
Well, it was a fascinating talk. Really enjoyed the last hour and the discussion as well. Right from the history, as you mentioned, and
50
it was
years.
nice going.
50
Yes,
years.
And being working in pediatric neurology for nearly 25 years, you also go through your own sort of life cycle, like
Yes.
you're talking about Reye syndrome, which we learned about or saw cases of as the interns and residents in our lifetime. And then later on, when I was working in the muscle unit in Hammers, first we picked up with Francesco Montoni, which was again a learning experience at that time. And then over the years, we learned about the sodium valproate and the metabolic concerns that it has. So it was very nice and fascinating listening to all of that, the history, and then coming on to what we have learned more recently, like the LCHAT and MCAD and SCAD deficiency that you mentioned, as well as the treatments and the future direction. So it's fascinating, and thank you for sort of spending time with us, as well as the discussion that was done by Dr. Verma and yourself. We are all sort of keen on knowing about what we can do without having diagnosis, a full diagnosis, a full workup, like you said. And we talk about mitochondrial cocktails, as we were talking about in suspected cases.
Yeah.
So those would be my comments.
Well, I thank you so much for your wonderful comments. And, I think I'm curious, are serum acylcarnitines, are you able to do those in India?
Yes, I think
Yes,
as a
we do
part
that
of TMS.
yes, we do it. We have a blood test for tandem mass spectrometry, and that's part of that panel.
Okay.
So that's freely available in India, yes.
Because that really is, that's what newborn screening really rested on. I tried to put in caveats where it might be a false negative. So if you really believe that this group of disorders are affecting a child, then one just has to keep trying. And most importantly, in a critical catabolic situation, you can get a lot of information. Like when they hit the emergency room, if someone can do those blood spots right at that time, that's the highest chance you have. And I think serum acylcarnitines are very helpful for chain length specificity and the species type. So you might even be able to nail what the enzyme defect might be. So, and they're easy to do. It's just a finger poke on those Guthrie cards and then dry them. I used to have a wall of blood spot cards from my clinic, and dry them, put them in a plastic bag and mail them, and that really is a very, very helpful way to try to get to the diagnosis. So I would strongly recommend that. I think it's very helpful. But I will caution you that it can be negative and the patient may still be affected. So you have to keep looking. And, and also in the newborn period, there are patients like trifunctional protein patients who will present very early before your results come back. So that's where if you're highly suspicious, then dietary modifications are really important to be put in place to limit the long chain fats.
Thank you, Ingrid. We do have the Guthrie cards. Do you have 5 more minutes? I know we are reaching to
Sure.
time, 5 minutes. Then
Sure.
I'll request Sangeeta and Vaishak. There are 2 questions there, so they can ask those 2 questions which are there in the chat. And I did not take permission beforehand. I forgot. We were recording the session and we put it on the website of AOCN. Is there permitted to put it on this?
Yeah, sure.
Okay.
Of
Thanks.
course.
Thanks. Sangeeta, Vaishak, please ask.
Yeah, we have one more question with regard to the use of steroid. Where exactly can we try a steroid in the metabolic crisis of patients with FAOD? Can it be tried of various subtypes, or it is only specifically indicated in LCHAT deficiency?
Yeah. I mean, the reason that we used it in this boy was because we ascertained that he had very leaky muscle membranes. You know, as I said, his resting CK was 50, and just walking, you know, like 10 yards, his CK had gone to 2000. So there was strong presumptive evidence there that he had very, very leaky muscle membranes. So that was the reason that we applied it in that situation. I have not, you know, and it made a big difference in, you know, completely restoring his muscle power. And that, of course, really improved his quality of life. I'm not aware of it being used in the acute situation in a fatty acid oxidation defect. I don't think that there's really currently, what should I say? There are no like randomized control trials, or I haven't seen any sort of empiric trials using steroids in an acute situation. I could be something that could be investigated, but there is nothing in the literature at the present time that I'm aware of.
Sure, thank you. Dr. Vaishak, you would like to discuss some questions?
Yeah. Thank you, Professor Ingrid, for that excellent talk. In the short time, you have consummated about FAOD from the very basics to the most recent advances. So this was the last academic activity by the Neurometabolic and Neurogenetic SIG this term, and we are happy to conclude this month's activities with this brilliant session by Professor Ingrid, as well as the presence of Dr. I.C. Verma and many experts. So there were many learning points. To me, one eye-opener point was that carnitine should not be given in the LCHAT deficiency. That was kind of a new point for me. I am sure for many it would be, because what we do mostly is at the slightest doubt of an inburner of metabolism, we start carnitine. But now onwards, we'll be careful more. There are
I
two
think
more
in the respiratory chain disorders, it's not an issue. But in these long chain fatty acid oxidation defects, there are unfortunately cases in the literature of trifunctional protein LCHAD patients acutely getting IV L-carnitine and having major catabolic decompensations. And again, if you think sort of pathophysiologically, long-chain acyl-CoA is becoming a long-chain acyl-carnitine, very detergent, myoglobinuria, arrhythmias. And that's something that I think really needs to be avoided. People may argue that at some point, the amount of carnitine in a long-chain defect over time may become rate limiting, but I think one would have to really look at that carefully and certainly avoid it in the acute situation, because that's, I think, where the greatest amount of sort of catabolic crisis could occur. I would strongly advise being medically prudent there and not giving it.
There was a comment from Dr. Gauri Pasi. There was an epidemic in 2014 where there were children specifically from the district of Muzaffarpur, that's a state in Bihar in India. They were having cerebral edema and hypoketotic hypoglycemia. And actually, it was not a single epidemic. It was going on for many decades, so almost every year. And at last, it was found that the culprit was a toxin MCPG in a fruit, lychee, and it was exactly mimicking an FAOD. So that was published in Lancet also. So there
Oh
was
my goodness.
Yeah.
Yes. I believe he presented that at one of the ICNA congresses, I think in Mumbai. Did he? Did someone not
Yeah.
present it there? And
Yeah,
it was
yeah.
beautifully deductively presented. I thought it was just a fantastic analysis. And the other toxin actually is hypoglycin A, which you get in unripe ackee fruit. So there were people in Jamaica who were eating unripe ackee fruit, and hypoglycin, I think it inhibits MCAD. And so they were having a fatty acid oxidation crisis, like a full-blown Rye syndrome. And, I've seen, since that time period, like in the early 1980s, we all read about Rye syndrome as being quite a major epidemic at that time. But I've seen cases isolated since that time. And ultimately, the children that had it had some heterozygosity for an inborn error of metabolism. And I think the last one had a urea cycle disorder. So that's why I think you have to keep your antennae up all the time, when and especially if something happens more than once, you have to start looking and be very, very tenacious so that you can get your diet, no stone unturned. Well, I always say, like a dog with a bone, you never give it up until you make your diagnosis.
Ingrid, actually, this acute encephalitic syndrome saga has been going on in Gorakhpur for long. Earlier, they were talking about Japanese bee, then it came the scrub typhus, then this lychee explanation. So like we have just going on studying, and we have also been doing a study in which we're trying to see all the toxins, all the metabolites, in addition to all the infectious and autoimmune. And also, I think we are getting very interesting results. We'll be publishing soon in that.
Yeah,
and
well, that's fantastic. I mean, I always say, I know that valproic acid is the second most commonly used anticonvulsant, and that it is a very good anticonvulsant. But from my perspective, as a mitochondrial neurometabolic person, for me, I just see mitochondrial toxin because these cases of valproate hepatotoxicity, and we've seen. We often see a case every year or every 2 years. And, I always say, please watch these kids carefully. And usually the first sign is a change in behavior. So either they start getting drowsy or they get hyper irritable and hyperactive. But that's usually the very first clinical sign that something's going off. And the hepatology people, because we had a very interesting presentation, where we always measure liver functions, AST, ALT, ammonia, et cetera. But they said that the very first test that should be asked for and most sensitive is the INR, because that's a biosynthetic enzyme required. So they said, if that starts going off, then be suspicious. So it was a pearl. So
as an extension to that discussion, Professor Ingrid, would you advise to avoid aspirin in mitochondrial cytopathies or any IEM?
Yeah, because it has been shown very nicely by Doris Trauner in a mouse model to inhibit palmitate oxidation. So, if you're inhibiting a pathway that's trying to generate ATP, and you already have insufficient ATP production, then it seems counterintuitive to give something that would inhibit one of those pathways. Like in North America, we just say use Tylenol. That's generally, or ibuprofen. But we don't use aspirin anymore in children. And I think that really helped to decrease the prevalence of Rye syndrome. Also, that particular influenza B virus, as viruses come and they go. So I think it was like the perfect storm. You have the wrong virus with the wrong medicine and with a predisposition.
Another question, is there any role of steroids in MADD, glutaric aciduria type 2? Not in the acute, but in the chronic situation, because there was a case where MADD was suspected, and even before the confirmation, methylprednisolone pulse was given, for which the child responded. So What's your take
Well,
on that?
Yeah, I just don't know. I don't have that experience. I mean, if you find something to be useful and there are no negative side effects in that situation, then that's based on your clinical experience. I haven't seen anything really published in the literature, you know, in empirically or in any sort of RCT. So glutaric aciduria type 2, what was it? Was it ETF or ETF dehydrogenase deficiency? Do you know what the specific underlying defect was?
No, it was
I mean,
not.
they will have short, medium, and long chains. That's for sure. You know, they accumulate everything. So, yeah, I don't think there's really literature out there.
Dr. Bijak Patra has asked, does hyperammonemia and lactic acidemia occur in short chain acyl dehydrogenase deficiency?
They can get a bit of lactic acidemia because the ethylmalonic acid inhibits mitochondrial CK. It inhibits complexes 1, 3, and 4. So if it does, then that would be a good source for generating the lactic acid. I don't believe I've seen any cases with hyperammonemia. But that said, I mean, we know that short and medium chain acyl-CoA is accumulating. In this case would be short chain acyl-CoAs. There is some literature about the inhibition of carbamyl phosphate synthetase in the urea cycle, but I haven't seen that reported in a particular case. But I haven't done like a detailed search on that. But certainly a bit of lactic acidemia is possible. And actually another point, just sort of mechanistically, which I love that you're asking mechanism questions, is that with LCHAD is an NAD dependent enzyme. And it sits in the inner mitochondrial membrane. It's one of the largest fatty acid oxidation enzymes, having 4 alpha and 4 beta subunits. But it often will have a little bit of lactic acidosis, not super high, not like what you see with the respiratory chain defects, but a bit. And of course, the long chain L3-hydroxy acylcarnitines. And with complex 1 deficiency, which is the most complex of all of the respiratory chain complexes with its 45 subunits, it also sits in that inner mitochondrial membrane. And I think that these two are interlocked in a way, because with complex 1 deficiency, you can also see some long chain L3-hydroxy acylcarnitines. Not a lot, but a bit. And it's also an NAD linked enzyme. So it's interesting that they're kind of sitting synergistically with each other and that you get some biomarkers from either one showing up. So.
Thank you.
Thank you. Thank you so much. I think we'll take your guidance and support for something in the neurometabolic neurogenetic SIG. And we finished this SIGs this week sessions because we have divided the Wednesday sessions we are having every Wednesday, 8 to 9:30 p.m. IST, but we have different SIGs take every month. But the SIGs will continue to do their CMAs, position papers and statements. So maybe, you know, we will take your guidance for that. And in the future, I really you know, on behalf of the entire Association of Child Neurology, I thank you for having sparing your so much time, and it was a really fascinating, amazing talk. And as usual, you are an amazing orator. And I will hand over to Mahesh to say the final word of thanks and invite us to the CP-SIG. He speaks. I'll ask Asmita. We missed Biju because of his traveling. She can show the screen. I have just sent her the link of the talk he is going to deliver this Saturday. The topic is very interesting. I just sent the Facebook page from my Facebook to her.
Oh,
so, yeah.
Excellent.
Yeah, this is an extensive
Okay.
plantar response. This is on the Facebook from the ICNApedia. I was tagged. Yeah, so I think this topic is so exciting and interesting.
Absolutely.
So, yeah. You can
Yes.
stop sharing. Yeah, stop sharing. And Mahesh, we also get in
Thank
the
you.
newsletters. Yeah, we get in the newsletters. Yeah.
Thank you. I
Thank
really
you.
appreciate that.
Yeah.
I just want to make sure that people are aware, because I think that the quality of lectures have been truly remarkable. And it's, what should I say? It's very much the approach of Leonardo da Vinci. He always said, don't learn from others, learn from nature. Study nature. Nature will give you the answers. And always be curious and always be passionate about what you do. And he had the most amazing Renaissance intellect, and he connected arts and sciences in such a beautiful way. And that's what we're hoping to emulate somewhat in this series. So
Absolutely. It's a wonderful series. But, if you read in Menke's, it says, in the chapter, this planter is something you can make it upgoing, downgoing, or mute. So I mean, it's up to the person who's doing it. I remember reading it in my, MD days. It is in the first chapter of the old Menke's, the blue color one,
Oh, yeah.
because I
Yeah.
started reading with the blue color. Mahesh, over to you.
I thank Dr. Professor Ingrid for a wonderful talk on fatty solution defects. I like to thank both our subject expert, Dr. Arijit and Dr. Biju, and our moderators, Dr. Sangeeta and Dr. Vaishak, for conducting this session.
And Dr. I.C. Verma.
I.C. Verma. And from next month onwards, cerebral palsy SIG will be taking over. And the actual program I'll be putting on WhatsApp group, and I'll be emailing all the US members.
As well as the Facebook, Twitter, X. I'm sorry, not the Twitter.
Okay.
Elon Musk may be angry. And Instagram.
I request all the ESN members to attend in big numbers. Thank you. Good night.
Have a great day, Dr. Ingrid. Thanks.
Yeah.
Bye.
Thank you so much. Thank you so much, Dr. Ingrid.
Thank you. Thank you for the lovely invitation and the good commentaries.
Thank you.
Bye-bye.
Bye.
Thank you.
Thank you, ma'am.